So now behave yourselves, you are getting recorded, okay? Right, and I'll pin my video and then off we go. Right, okay. Okay, that's fine. Right, fine. Right, okay. Now today's topic, right, is on endometriosis. Now, let's talk about this. Now, first of all is the definition. Okay. Now, what is endometriosis? Endometriosis is when cells of the endometrium, which is lying in the inside of the womb, is found anywhere else in the body, it's endometriosis. Okay. Now, that is a very simple explanation. But there's something else you need to understand. There is one special place if endometriotic tissue is found, it's called another name. That is, if the endometrial tissue is found inside the myometrium, it is given a special name which we call adenomyosis. Okay, right. So the so what you have to remember is adenomyosis is a type of endometriosis where the endometrial cells will invade into the myometrium. Clear? Right. So now, if you look at this definition, why does it happen? We actually do not know very much. Although things are happening, things are, people are finding a lot of theories. But one of the basic theories is that during each menstrual cycle, blood falls into the peritoneal cavity through the tubes. Okay. But that happens in almost 95 to 100% of women every menstruation. Most of the women, right, will have a bit of blood in the abdominal cavity or the tummy, right? But what happens is, in some women, for some reason, these endometrial cells, along with their tissue, right, can implant into the peritoneum of the cavity. So it sort of invaginates and implants, and then it will start to grow there, right? So it can implant into the ovary or any place, and then it starts to grow there. So only in some women that this can happen, because in most of the women, what will happen is the peritoneum and the pelvic tissue, they will just kill it and send it off, right? So in some women, for some reason, they have the ability to implant, or in other words, the peritoneum or the covering of the pelvis has lost its ability to throw off or kill off the endometrial cells that are trying to implant. In most women, that happens. So therefore, they do not develop endometriosis. But in some women, they happen. So it's common as almost close to 10% of women may have endometriosis in their reproductive age, right? And if you take the population of infertile women, right, all women about 10%, got it, in the reproductive age. But if you take the infertile population and see how many of them have endometriosis, you might hit percentages as high as 40%. Do you understand? Right? Do you all understand the difference in between what I'm trying to tell you? I'm trying to tell you is that all women, there'll be about 10%. But however, if you take only the infertile women and find out how many of them have endometriosis, they will hit about 30 to 40%, right? So it's a very common disease. It is so common that in most countries, we have, in most countries, there will be specialized centers treating only endometriosis, right? And these are, most of them are minimal access surgical centers. And so therefore, it is essential, and the government spends lots and lots and lots of money just to treat endometriosis because it is a hugely significant problem, right? Now, what are the two biggest problems that endometriosis can give? Two biggest commonest problems. Number one, remember children, it's pain. Pain that is debilitating, pain that is so difficult that sometimes they cannot go about their day-to-day work. They cannot go about even sometimes get off from the bed. Sometimes they require very serious analgesics, right? I treated a woman who became a narcotic addict because she was addicted on pethidine, because she was doing so much of narcotics just to go over that period of pain which she has, right? She gets addicted. Do you understand? So the pain is extremely severe. So some women cannot get off their beds, right? It's so debilitating that their whole life is interrupted and messed up actually with the pain. The second commonest or the biggest problem that endometriosis causes is infertility, problems with fertility. Why? Because for a patient to become fertile, the inside of the pelvis and the coverings need to be very, very smooth and uninterrupted, right? Okay. Let me just mute your right. Okay. So the covering needs to be very smooth and uninterrupted. Why? Because the process of fertilization or becoming pregnant requires a very clear pelvis. Why is that? Because the ovary needs to put out an egg, okay, which is called ovulation. Okay. Then you have a tube which should not be stuck anywhere. And due to chemostasis, because there's a chemical change on the surface of the ovary when there's ovulation, the tube needs to go over it and cover the ovary. So ovulation happens not randomly. Ovulation happens right into the tube. So that is called an ovum pickup. So to move, the tube should not be tethered and there should not be adhesions around the tube, because it needs to move over the ovary, right? And if there is endometriosis and chemical differences there, because the tube starts to go over the ovary due to chemotaxis, because there's a chemical change and the tubal ends, which are the fibria, sensors it, and it goes over and covers the ovary. So the ovulation is not random. It just doesn't fall. It just directly ovulates into the tube. Then the egg lives at the end of the tube for about 48 hours. There's a swimming pool there at the fimbrial end. Okay. So nice, warm, full of nutrients, and you can imagine the egg floating around in that. Okay. And it's very, very comfortable. However, if there's endometriosis, then there are chemicals in it. And then it becomes toxic to that particular egg. So conception might not take place, right? At the same time, the sperm is deposited at the same time or any time later. The sperm is deposited at the end of the vagina and it swims up. But if there's endometriosis, because of the chemical changes, then the environment in the tube and in the uterus itself may be toxic to the sperms itself. So it might not even reach the egg. So it swims up the tube, right? And then falls onto that nice swimming pool with the egg swimming around in it. Okay. So normally when sexual intercourse takes place, the sperm can live at the end of the vagina for about 5 to 7 days, right? So usually if regular intercourse takes, that is 2 to 3 times a week, there will always be a sea of sperm at the end of the vagina. So it doesn't really matter when the ovulation takes place, because the egg will fall right into a swimming pool full of sperms. Got it? So sexual intercourse need not coincide with ovulation to conceive. So the advice generally is have sexual intercourse 2 to 3 times a week for conception. Okay. But if there's endometriosis, what happens is the fluid may be toxic, the environment may be toxic, it might be spermatotoxic. At the same time, even if conception takes place, then the tube must nicely push it very slowly at a very even space, right, towards the uterine cavity. But this journey is very specific. It has to take exactly 5.5 days for it to come down. While this this timing is very important for two things. Number one, the embryo must develop into a stage where it is able to implant in the cavity. So the trophoblast must have invasive properties by the time it goes. So if it goes very quickly, it will not have this ability and it will just get pushed off. If it goes too slowly, it will get the invasive abilities quicker and therefore it will implant in the tube and you get what? An ectopic pregnancy. You all understand? So it needs to be timed exactly, and for the timing to be exact, the tube, the inside of the tube must nicely push it at a very even space, which is chemically and hormonally modulated, and the tube must not have, convolutions, tethered, additions, problems. So then it's nicely pushes the embryo until exactly 5.5 days, it will fall into the uterine cavity. At the same time, this 5.5 days is very important because the uterine cavity is getting prepared for implantation. Okay, and therefore it needs this very correct timing for the embryo to go there. But if there's endometriosis, the whole process gets destroyed. Do you understand? The tubes are adhered, the muscular cord may be then, the ovary, the chemical environment, everything. So that is why there's a huge problem with endometriosis, because the ovaries may be having endometriosis, which are called endometriomas, then everything will be adhered. So therefore, it can have all these problems. So the two biggest problems in endometriosis, if you all ask, are what, children? Biggest problem is pain. The second biggest problem is infertility, and usually women will present with both, right? However, there will be women who have had children and are having pain. So they will be coming to you because of the pain. There will be women who are having endometriosis, no pain, but are infertile, which are rare. But of course, there may be, because endometriotic, what we see, and sometimes there may be large endometriomas, large lesions, but they do not coincide directly with the symptoms. So some women may have a bit of endometriosis with a lot of symptoms. Some may have a lot of endometriosis with a bit of symptoms, but those are rare cases. Normally, we see a lot of problems and we see a lot of pain as well. Do you all understand? Right? However, the other two extremes also can exist. So what are the types of patients that are going to come to you? Number one, patients who are having pain, severe pain, right? It may be chronic pelvic pain, it may be debilitating pain during the periods. Usually it is chronic pelvic pain, which has gone on for a long time with exacerbations and dips, high ups and dips. So during the period, it gets very extremely painful and then less painful. And so all the time they are in pain, right? And they will have all the pain syndromes, which we spoke about last time, which remember I told you, premenstrual pain, menstrual pain, post-menstrual pain, dyspareunia, backache, right, bladder pain, all those will persist or be there in these women. This saw that, so there will be pain syndromes in those women. Then, so women will come with pain, women will come with infertility, and women will come with pain and infertility in endometriosis. Do you all understand? Very rare, some cases will have different problems. Like, for example, with endometriosis, it can crush the ureters at the bottom. So when the ureters are crushed at the place where it goes into the bladder, what will happen is you will have hydroureter, and the kidneys will swell up, and that will cause hydronephrosis, and that will cause the kidneys to fail. So some women rarely will go to the urologist. They will say that there is hydronephrosis, the kidneys have failed, she's in kidney failure, and to find out later on that it is due to endometriosis, that the ureters have been crushed and she has developed hydroureter and hydronephrosis, right? So these are the ways in which women present to you in endometriosis. Okay, so now let's look at how the symptoms develop. Basically, all right, we need to understand the symptoms to understand the disease. Basically, if you are looking at the pain component of it, everywhere the endometriosis goes and sits and lives, right? because endometriotic tissue will implant and then they will grow, because there is also not only the upper layer but the stroma as well of the endometrium. So it can go like an endometrium. And what they do is when they live there, they bleed with the hormonal cycle. So as the ovaries produce hormones, they also bleed, right? So therefore, everywhere the endometriotic tissue is, it will bleed, and everywhere it bleeds, because these are normally spaces which are confined. When it bleeds, it will cause edema, it will cause expansion, that will cause ischemia, and ischemia will cause pain. Do you understand? At the same time, where these things are, nerve elements will get involved in those, and that will cause endometriotic nodules, and that will give continuous pain, and the pain will increase with the period, right? So this is, now let's look just at the pain component. So we will say, okay, woman will come and tell you what the pain component is, right? So my daughter set up. Okay, so let's start off again, right? If you cannot see it, we'll just give this up and then start, right? So let's start. So now, if a woman comes with pain, can you see that now? Yeah?
Yes, sir.
Yes, sir.
Right. So the pain, remember, is a central thing, and what we have to understand is that the pain can contribute to different types of things, right? So how is this pain generated, right? Number one, if there is endometriosis in the ovary, and if the woman has endometriomas, which are called chocolate cysts, because when you cut them, you will have chocolate material come out of it, right? So if you have pain, right, and that, if there's an endometrioma, then that can endometrioma, got it? So that can contribute towards the pain in the woman. Is that clear? Can you see me? Right? Yeah, okay, you all are happy, right? So the next thing that can contribute to a woman with endometriosis is, say if there's endometriosis along the ureters. If you have endometriosis along the ureters, what will happen is the ureters will get crushed at the beginning, and then that will cause the ureters to swell up. What is that called? That is called hydroureter, and you can have hydronephrosis, right? So that will cause severe backache and loin pain. So that the woman can have, right, back pain, right, and loin pain, right? So why is it caused? It's caused by, okay, it's caused by the ureters. Ureters, okay? So that can cause pain there, okay? The next thing is, if there is a nodule in the bladder, so there's nodule in the bladder, and that will cause severe pain when she passes urine, okay? And what does that cause? That is what we call it bladder pain. So the bladder endometriosis can give rise to pain, okay? That is the other thing. Next is, the other thing what we have to remember is, right, if there's endometriosis on the bowel, what happens? Give me a second, please. I'm getting a call, one more. කවුද ඇනුම් අරින්නේ? Avisha, is that you?
No, sir, I'm muted.
Right. Okay. So now if there's endometriosis on the bowel, all right, what does that mean? Because the endometriosis is sitting on the bowel, for it to be complete, if defecation has to be completely painless, when the bowel expands with feces, right, it should expand without pain. And when there's defecation, the bowel needs to contract to send it out, right? But if the muscle coat is infiltrated with endometriosis, it cannot expand and it cannot contract very well. And it causes severe pain. And what is that called, which I taught you all last time? That is called dyschezia. What is dyschezia? There's a lot of pain when she starts to pass, open her bowels. And when it passes, then there's a huge relief from the pain. So that is dyschezia, right? So that if there's bowel is there, if there's bowel endometriosis, that also can give rise to pain, right? If the nerves in the pelvis, right? What are the nerves that we are trying here? If there is obturator nerve involvement, specific places in the thighs and on the legs will have pain and discomfort. If the sciatic nerves are involved, she will get pain down from the posterior aspect, the pain will go down the leg, right? If there are different sympathetic or parasympathetic plexus are involved, you can have diffuse pain around it. Then if the genitofemorals are involved, because there is genitofemoral, the labial side or the vulval side can have pain. Do you understand? So any type of neural pain can be there in endometriosis. Remember what are the nerves which I told you where the endometriosis can involve? It can involve the obturator. It can involve the genitofemorals. It can involve the sciatic nerves. It can involve the hypogastric plexuses, and it also can involve the S2, S3, S4 nerve roots, right? So depending on the involvement there, the pain can be reflected onto there. What is the next thing that can give pain in the pelvis, right? So nerves also can give pain. Then the uterus itself. What is there in the uterus? Children, is adenomyosis. So if there is severe adenomyosis, then the woman also can have pain that is coming from the uterus, right? What is the next thing that she can have pain with? If the muscles of the pelvis are involved, my writing is getting better, right? If the muscles are getting involved, right, I'm getting the hang of it. So that's why it's, so initially they look awful, now they're slowly coming back to normal, right? So if the muscles of the pelvis are involved with endometriosis, what happens is when there are endometrioid deposits on the pelvic floor, when there are endometrioid deposits around the structures, but also involving the muscle and the fascia, she will have pain in that area as well, right? Because the whole pelvic floor is a muscle, right? There are lots and lots of muscles in the pelvic floor, mainly 3 or 4, right? The main one is, as you all know, is what? Is the pelvic floor is made out of 3-4 types of muscle. The levator ani is the biggest muscle there, which has 3-4. If the fascia on the muscles are involved with endometriosis from the inside, then they will have muscle pain, right? Then what else is there? So these are the main components, and of course I forgot the peritoneum. Peritoneum, right? If the peritoneum is involved, the surface, there can be surface deposits everywhere that causes a severe amount of pain, right? So that is number. What is the other thing that causes pain here? The rector the rectovaginal septum. If there is nodules in the rectovaginal septum, where is the rectovaginal septum located? You have the vagina and you have the rectum. In between, there is a septum, which is called the rectovaginal septum. Because the vagina has its own covering, the rectum has its own covering, and in between, you can go very easily, and that is called the Denevelius fascia. I don't know whether you have heard of it. So during dissection, you can just go in between. And sometimes endometriosis lives there. And what happens then? When it lives there, what happens is there's a severe amount of pain, especially during sexual intercourse, right? So if there is rectovaginal septum endometriosis, that also can contribute to the pain, right? So all these, the muscle, the bladder, the nerves, the uterus, the ovaries, the ureters, the bowel, the peritoneum, the fascia, wherever it is involved, can cause the woman pain. Do you all understand how diverse pain can be? Because we are just talking about the pelvis here. Got it? So these are the ways in which endometriosis generates pain. Is that clear? Right? So I'll stop the share. Right. Can you all see me now, children? Yeah? All right. So do you all understand how pain is generated? Right? So one of the main things which I forgot to actually draw is pain can, the endometriosis can especially be on the uterosacral ligaments. Now, what are these uterosacral ligaments? Uterosacral ligaments are the two ligaments that are the biggest ligaments in the that is holding the uterus up. It connects the uterus to the sacrum, right? And that is the biggest support. So if you look from this inside towards the bowel, right, there is the uterus, and then you can see the uterosacrus, and the bowel goes underneath. So between that and the uterosacrus, you see the pouch of Douglas, right? So most of the endometriosis which you see will live around the uterosacrus, right? So these are the places where the endometriosis lives, and this is where the pain is generated for these women. Now, for infertility, I told you how it happens, because it disturbs every part of the pelvis, and therefore that also causes, that can cause infertility. At the same time, the generation of pain is caused by the mechanisms which I told you. Okay, is that clear? Right. So the next thing is, give me a moment. Today I'm getting a lot of calls. Right, okay. Right, let's hope I do not get disturbed. Right, so the next thing is, so we have, what is this? So we have pain and we have infertility, right? So these are the most of the commonest symptoms that a woman is going to come with, right? So now let us just go quickly through the pain syndromes that women with endometriosis will come to us. Okay, what are we discussing? We are basically discussing the symptoms or the complaints that the woman is going to come to you. So every time you think endometriosis, you should be able to connect these pain syndromes, and you might think, okay, is this endometriosis? Okay, right. Let's look at the pain syndromes, because I have discussed them last time in pelvic pain, but I want you to just remember them and the mechanisms how they generate pain. Number one is menstrual pain. What is that? Dysmenorrhea, right? How does dysmenorrhea happen? Dysmenorrhea happens when the woman has endometriosis outside. So during the periods, she bleeds into the uterine cavity, through the cervix and out, right? So that is the normal flow. However, at the same time, because there is endometrious tissue outside, she bleeds there as well. So there is bleeding outside. So there is bleeding outside and inside. So therefore, the pain will increase a lot. So she has dysmenorrhea, right? Then there is the second syndrome is premenstrual pain. So she starts to bleed. Before she starts to bleed or has menstruation, the endometrial tissue will become secretory, because it becomes, there is secretions coming out. Okay. So therefore, it expands, there is secretion, and therefore, when the endometrial tissue is outside, it causes expansion and edema causes pain. And therefore, the pain starts before the periods as well. And it increases with the period, because those places also start to bleed. Got it? Postmenstrual pain. What is postmenstrual pain? Postmenstrual pain is when there is pain after the period. Why is that? Because she has bled outside, right? And it takes some time for the blood to get absorbed. And therefore, that is called what? Still the pain continues even after the bleeding has stopped. Because outside the tissue, outside the womb, it takes some time for the blood to get reabsorbed. So you have post-menstrual pain. So the pain continues even after the period. Got it? Next is what? Next is the other syndrome is what? Dyspareunia. Why? For painless intercourse, what should happen is that the posterior fornix must expand freely, right? But when there is endometriosis, especially in the rectovaginal septum and the uterosacrus, because the end of the vagina is near the uterosacrus. The end of the vagina and the uterosacrus are near to each other. So what happens is, in there is endometriosis of the uterosacrus and in the rectovaginal septum, the expansion is not possible. It is tough. It does not stretch, and therefore the pain becomes extremely severe during sexual intercourse. So you get dyspareunia, right? So how many syndromes now? 4. Premenstrual, menstrual, postmenstrual, dyspareunia. The other syndrome that they get is severe dyschezia, which I explained, right? When she wants to defecate, the pain starts. After defecation happens, the pain disappears, right? But during defecation, she has severe pain, which is dyschezia. Okay, dyschezia. So dyschezia can happen. Okay, so 5 pain syndrome. 6, if she has ureteric involvement and hydroureter hydronephrosis, she will get severe back pain and loin pain. So that is number. Next, if there is a bladder nodule and the bladder wall is involved, or if there's a bladder endometriosis growing into the bladder, or if there's a bladder wall is involved, what do we have? She has pain when she passes urine. So she has bladder pain. Okay, right. So basically, those are the most. Then of course I forgot neuronal pain or neuropathic pain. If the nerves are involved, depending on the nerve, which nerve is involved, she will. If the sciatic nerve is involved, she will have pain going down the behind the thigh. The pain will be there. If the obturator is involved, where the obturator is supplying. If the genitofemoral is involved, where it is supplying, the pain will be there. So neuropathic pain will be there. So those are the commonest pain syndromes a woman will come to you with, right? So if a woman comes to you with infertility and she will have these pain syndromes, then in your mind, you have to understand, okay, is this endometriosis? Is that clear? So these are the ways that women will present to you, right? Of course, if they are very large endometriosis and all, then, and remember, there are rarer ways in which they present. If they have endometriosis of the lung, they will have blood coming out when they cough, and they will have shortness of breath. If they have endometriosis of the eyes, they will have bleeding from the eyes when she has endometriosis. If there's endometriosis of the umbilicus, they will have blood and severe pain in the umbilicus with a nodule appearing during menstruation, right? If they have endometriosis of the pleura, then when they breathe during menstruation, they will have pain. If they have endometriosis of the diaphragm, which is not very uncommon because I have seen 3-4 cases, then when they breathe, then they will have pain during breathing. Do you understand? So endometriosis can be anywhere, but commonly it is always found in the pelvis, and in the pelvis also it is commonly found very, very deep, right? So there is superficial endometriosis if we classify, and there is a deep infiltrating endometriosis which will affect the bowel, the uterus, the rectovaginal septum, the ends of the ureters. All these can be affected in deep infiltrating endometriosis, right? Is that clear, children? So now you all have to understand what I've told you, the pain syndromes and how they cause infertility if endometriosis is there. There can be a combination, and how the pain in this person originates. So you all understand how the endometriosis can go rise to these pain symptoms. Is that clear? Right. So now let's go to our next segment. Okay. So now we understand the symptoms. Now next is, how do we diagnose? Right. That is the most important thing. How do we diagnose endometriosis? The most important thing is that in your brains, when a woman tells you that she has these pain symptoms, or she comes to you with this story of infertility, in your brain, if you are looking at a woman in her reproductive years, the diagnosis of endometriosis must always be there, right? So you can suspect, or you can become suspicious, and you can think, okay, is this endometriosis if she has one of those pain symptoms? Of course, the pain symptoms can be due to something else, but this is something very, very important which you can understand, right? So the clinical history will make you suspect. What is the second thing? Second thing is abdominal examination, right? Usually only if there is a large endometrioma, you'll be able to palpate a mass. So that may be a large endometrioma, and it will be painful, and you may be able to understand by palpation, right? Of course, if there is obvious bleeding, like a very painful nodule in the umbilicus, then that is umbilical endometrioma, right? But the other things you might not be able to suspect very easily or elicit when you do an inspection or a palpation. Next, one of the most important ways of clinically finding endometriosis is doing a vaginal examination. When you do a vaginal examination, what are the findings that we often find? Number one thing is it becomes extremely painful for her. The second thing is, once you do a vaginal examination, and you should be able to feel the uterosacrals on both sides, and they are very nodular and thick, right? And they are very painful. Next things, the uterus itself will be fixed and retroverted. Normally, you should be able to move in bimanual palpation, you should be able to move the uterus very free. But if the whole uterus is stuck, and then it is stuck onto the retroverted and stuck, then you get a fixed retroverted uterus in vaginal examination. And it's that you'll be able to think about endometriosis there. The next thing is, in the rectovaginal septum, in the posterior fornix, you should be able to feel nodules, which are very hard, like stones, right? They're very painful, and you can feel these nodules in the posterior fornix. And that also will make you come to a quick diagnosis of endometriosis, because those are nodules in the uterus acrus and the rectovaginal septum, right? And then if there are ovarian cysts, yes, in the lateral fornices, you may be able to feel an ovarian cyst, right? And if there is adenomyosis, when you press the uterus between your fingers, the uterus will be tender and painful, right? So in a vaginal examination, most of the time, you should be able to find or discover endometriosis. Come back again in a vaginal examination. Number 1, fixed retroverted uterus. 2, enlarged uterus due to adenomyosis. 3, it will be a tender uterus. 4, the fornices will be tender. 5, the uterus acrus will be thickened and nodular and tender. 6, you will get rectovaginal septum nodules, very tender, marble hard nodules in the posterior fornix. All these will, any or most of them, or a combination of some of them, will tell you that she has endometriosis. Those are the vaginal examination findings. Is that clear, children? Right. From there, we come to exam. Remember, I told you investigations are always, some of the important things in investigations are we need to arrive at a diagnosis, right? So the next investigation is, the most important thing is a ultrasound scan, right? So when you do an ultrasound scan, you'll be able to see each of these elements, right? Specifically, if you are very good at ultrasound scan, you'll be able to see each of these elements very, very, very clearly. What are these? Number 1, we'll be able to see an endometrioma if there's ovarian endometriosis. And the endometriosis will have a very specific shape. There'll be all blood inside, and there, because of the calcium that comes out of the blood cells when they are degenerating, there'll be specks inside where the light is, the ultrasound is reflected off. So you get all these small specks inside the ovary, right? What is that called? So it is called, very specific, it is called an endometrioma, right? So that is number. So it has a very specific look, a very thing which you can recognize very easily, because that's all blood inside. Okay. Then in the uterus, what will we see? We will see adenomyosis sometimes or most of the time. What is adenomyosis? You will not see a clear myometrium. Now you have to have an endometrium and a proper myometrium. Okay. What happens is, you will have one wall becomes very, very, very thick. Usually there is asymmetrical thickening of the walls. Usually it is the posterior wall that becomes very, very thick, right? So you will have a haziness, and you can see that there are, in some places there are more concentration of these endometriotic tissue in bladder, and that those are called adenomyomas, right? And then the wall becomes very thick. And sometimes from the endometrium you will see the endometrial tissue climbing up sort of, and you can see them how they have infiltrated into the myometrium. So by ultrasound scan, you'll be able to diagnose adenomyosis. The next thing, the ultrasound scan will show you the thickened uterosacral ligaments, so which you can see, and you can look at the uterosacral ligaments by the transvaginal scan, and you can see the thickened endometriotic nodules. You can look at the bowel. Properly, if you do ultrasound scan, you can look at the whole bowel coat, the muscular coat, and you can see the infiltrating nodules inside the bowel as well, which you can diagnose. If there are nodules inside the bladder, you'll be able to see the bladder nodules as well. You understand? So we can see the bladder nodules there as well, right? So therefore, you can see the nodules in the rectovaginal septum, you can see the thickened uterosacral ligaments, you can see a fixed retroverted uterus, you can see ovarian endometriomas, right? And one of the other most important thing is, if there is a uterus and there is an ovary, and when you push your probe between the ovary and the uterus, normally they will go away from each other if there are no adhesions. Okay. And when you slowly release or come back with your probe, they will come back together. And they will slide against each other if there are no adhesions. However, if there are adhesions, if this is the uterus and this is the ovary, they'll be stuck firmly together. And when you push, they will not go away. Because you push from here, right? You push from here, but they will not go away. They will stay stuck together and they will move with each other. So that is one way of saying that the ovaries are adhered to the uterus and maybe to each other underneath the pouch of darkness. What are the things? Ultrasound scan will detect very easily hydronephrosis and hydroureter. Okay, you just put the probe on the kidney and you will the normal probe and you will see hydronephrosis, hydroureter. And what is one of the most important things which you can see is hydrosalpinx. What is hydrosalpinx? It looks like a sausage, right? Because what has happened is because of the adhesions, the ends of the tube has got stuck. Okay. So the one side, normally the tube is open to the peritoneal cavity and the other side is the uterus. But the side that opens into the peritoneal cavity is larger, the femoral end. Okay. The one that is on the end that ends into the uterine cavity, right, is what? Is smaller. So when the fluid is developed, the fluid will normally, the fallopian tube, all the fluid will normally drain into the peritoneal cavity. But due to endometriosis, the femoral end is stuck under the ovary and it gets shut, then a lot of fluid will enter. So what will happen is the whole fallopian tube will swell up, and that is what we call hydrosalpinx, right? And that will cause the tube not to work. It will cause infertility and it will cause a lot of problems as well, right? And that also can give a lot of pain, which I forgot to put in that chart, right? So what I forgot to put in the round chart pain, the tubes will cause pain, which is hydrosalpinx, and I forgot something else which I mentioned later on, right? Which also needs to go into that chart, which cartwheel, which I said that causes the causes of pain. Okay, right? So those are the ultrasonically which you can find. Yes, MRI can give you specifically, then you can do a MRI. MRI will give you specifically the sizes of the bowel nodules, the diameters of the bowel nodules, the locations of the bowel nodules, right? The bladder you can see specifically, right? And yes, if you are very, very good at in MRI interpretation, it can also give us the locations of all the rest of the endometrioid nodules. However, ultrasound scan is quite good enough for us to arrive at a lot of diagnosis and almost all the things we can see by ultrasound scan as well. So we don't need extremely expensive equipment, and with a good ultrasound and a good operator, we can discover most of the things in endometriosis, right? Is that clear, children? So if you ask how to diagnose endometriosis as a summary, what do we do? One of the most important thing is, right, if you ask, okay, how do you diagnose it? Number one is the history. Is that clear? And I have told you comprehensively what the history is, right? Number two, it's clinical examination. And I've told you how by palpation, which is rare because you need to have a large endometrioma. And then mainly vaginal examination will show you that there is endometriosis. I have told you the symptoms, right? Then from there onwards, you go on to what? The transvaginal scan and an abdominal scan, which will give you most of the places where there is endometriosis. To say that again, it will show you endometriosis of the bladder, it will show you hydrosalpinx, it will show you adenomyosis, it will show you endometriomas, it will show you the thickened uterosacral ligaments, it will show you rectovaginal septum nodules, it will show you bowel nodules, right? It will show you hydroureter, it will show you hydronephrosis, right? So all these, the only thing that ultrasound scan will not show you are the nervous nodules on the nerves. It will not show you the sciatics, it will not show you the uterosacral, the sacral, sacral nerve roots. It will not show you the genitofemoris, it will not show you the obturator, and it will not show you the hypogastric plexus, and it will not show you sciatic nodules, right? That is the only thing that the MRI can detect very well and the ultrasound cannot, right? So if you are suspecting any of the symptoms involving nerves, then you need to do a MRI. So investigation done. Is that clear, children? Right? Okay. So then, how do we treat endometriosis? Right? So therefore, remember, children, we treat endometriosis only on two bases. Number one, if it's essential that we treat endometriosis if the ureters and the kidneys are in danger. So there is no discussion about that. So what is the other thing that stems from that? Every time a patient with endometriosis comes to you, please, please, please do not forget to ask for an ultrasound scan KUB. Because I have seen so many patients where they have even performed surgeries in the pelvis and then they have just forgotten to do ultrasound scan of the KUB, and what has happened is they have missed the hydroureter and hydronephrosis completely, and the woman comes to you with renal failure and she might even require dialysis. I just recently treated a patient with bilateral hydroureter and hydronephrosis with one kidney at 40% and the other kidney at 15% due to endometriosis. But two surgeries have been done for her, and for some reason, the hydroureter and the hydronephrosis has been missed because somebody has forgotten to do a simple ultrasound scan KUB. So remember, for life, children, if you ever get a patient with endometriosis, please do a ultrasound scan KUB. Okay, right. So treatment is necessary. How do we treat hydroureter hydronephrosis? Either you can do a ureterolysis to free the ureter, right? And if there is no obstruction and we have cleared the ureter, you can leave it like that, right? However, if the ureteric muscle is destroyed and if there's no way which we can save that part, what we do is we cut it and then we take that segment off with endometriosis and we reimplant the ureter onto the bladder. So uterine or ureteric reimplantation is a choice if necessary. You all understand? So that is treating ureteric endometriosis. So that treatment is always surgical. Okay, we have no options if they have hydroureter and hydronephrosis. Okay. Next, if there are only mild symptoms, right, and if the main problem is pain, and if she has children but the main problem is pain, and if the pain is mild, then of course we can go for painkillers or medical treatment. Right? For the pain, you can give any type of painkiller. You can give paracetamol, you can give NSAIDs, you can give codeine, you can give a mixture of paracetamol codeine, which is Panadine in Sri Lanka. That is the trade name, right? That is a mixture of paracetamol and codeine. Then you can give suppositories, you can give paracetamol suppositories, you can give NSAIDs, anything. You can give any painkiller for endometriosis. Got it? So painkillers can be taken only during the period she has the pain, or she can take at a longer time. So that is possible. So those are painkillers which can be used. Okay. Usually, you know, we have an analgesic ladder. We go from one to the other, one to the other. One thing is what we can. One moment. Right. So you can start with simple paracetamol. You can go on to paracetamol and codeine. Then you can go to NSAIDs. You can combine NSAIDs with paracetamol, right? Then you can go to analgesics which are oral, which are narcotics, right? tramadol is a possibility. So all these we can say suppository routes we can change, we can do, try and give it, right? Then the next option is you can suppress endometriosis by using hormonal and maybe sometimes non-hormonal treatment, right? Now remember, most of this suppression of endometriosis, we have to suppress estrogen, right? Because estrogen is the driving force to cause the endometrial tissue to grow, and progesterone will make it secretory, right? So therefore, when we suppress endometriosis, something very, very essential happens. It suppresses ovulation also, because the patient's ovulation is extremely important. The ovarian hormones are very powerful, and then they will start stimulating the hormones, the endometriosis. So what happens is when we give hormones, right, or we have, what we have to do is we have to suppress the ovarian hormones or suppress ovarian. So therefore, no hormones, no stimulation, the endometriosis does not become active. Okay. So what are the things that we can use? If we are going to suppress hormones, then fertility is out. Why? Because you suppress hormones, you suppress ovaries, you suppress the ovaries, you suppress ovulation. So the woman cannot have children if you suppress ovulation. Do you all understand? So therefore, if the woman has fertility wishes with endometriosis, then suppression of ovulation is completely out. You can't do that. Okay? In those cases, mostly we might require to do surgery for them to clear the endometriosis and then go for fertility treatment. Is that clear? Now, how do we suppress? We can suppress in many ways. Number one, we can give very high dose progesterones, which is called depo-provera, right? Number two, we can give very low dose oral contraceptive pills. How does that happen? What we do is, when you give oral contraceptive pills, these oral contraceptive pills are extremely low dose, right? Very, very, very low dose. They contain estrogen and progesterone. So what happens is, because they contain estrogen, they also stimulate the endometriosis to a certain extent, but at a very low space. But because we give externally low dose estrogen and progesterone in continuous dosage, the brain thinks, okay, there seems to be some hormones inside, and therefore the brain stops producing hormones that stimulate the ovaries. What are these? FSH and LH. So the FSH-LH production is stopped because the brain is tricked into thinking that the ovaries are producing hormones. Actually, we are giving them from outside. So this very powerful FSH and LH, which stimulates very powerful hormone production, estrogen production of the ovaries, are stopped or blocked, right? So instead of that, we are giving low dose hormones. So endometriosis is stimulated, but they are not stimulated in a normal way, because normally the endometrium is stimulated. You have estrogen predominant initially and it thickens a lot. Then that thickened endometrium with estrogen, which is after the proliferative phase, will be converted into a secretory phase by the progesterone. So the thickened layer continues, and then there's a drop of hormones and then it bleeds. Okay, so a very thick layer bleeds normally, and that is called menstruation. But when we give oral contraceptive pills in low dose continuously, there is no FSH and LH, and you have estrogen, progesterone, small doses. So whatever becomes proliferative becomes secretory at the same time. So therefore, this layer that ends when, if there is a withdrawal bleed at the end, when you stop, if you stop the COCP, there's a very, very thin layer to come off. That happens in the endometriotic tissue as well. Do you understand? So the bleeding is less. There is bleeding, but the bleeding is less. Got it? So therefore, that is why we give continuous oral contraceptive pills, or we can give it 3 months, small gap. 3 months, small bleed. 3 months, small bleed. That is called tricycline, which you can use. So it'll stimulate endometriosis bit, but not to the extent that your own ovarian hormones will stimulate, right? So we can postpone the endometriosis from coming back by giving oral contraceptive pills, and that might also cause pain-free periods or periods with less pain. What is the third medical treatment? Then you can put in a Mirena or levonorgestrel releasing intrauterine system into the uterus. That can cause if there's adenomyosis, it can cause a bit of lessening of the pain because it will infiltrate into the myometrium. At the same time, it can also cause reduced bleeding during periods that can cause reduction in the pain. But Mirena does not infiltrate into the other areas outside, right? So it will not have any effect on the pelvic endometriosis as such. Okay. The next thing is you can give things like implants, which releases continuously progesterone, and that can cause the progesterone or the endometrial layers to thin out. So that can also be used. Implants, they release progesterone into the blood. That will give you contraception as well as slight suppression of the endometriosis, right? So those are the medication which we can use. And the most powerful medication which we can use are the GnRH analogs, which will completely suppress estrogen and progesterone in the body. The whole problem is we cannot give it for a long time because it causes two problems. What are these? It can cause osteoporosis, right? General, right? So that can cause osteoporosis and it can cause a reduction in the platelets, thrombocytopenia. So therefore, we cannot continue for a long time because the woman is going to have fractures. And therefore, because no hormones, because the woman needs for the skin, for the brain, for the bones, for every organ in the body, they require estrogen and progesterone. So if you suppress it completely, then it's not going to work out very well. Even if you give add-back therapy in small doses, still you cannot continue GnRH analog for a long time, although it suppresses endometriosis completely. So GnRH analogs we use with caution in only certain circumstances, right? But usually we don't give it for a long duration of time. Got it? So those are the medications which we can use for endometriosis. The third mainstay in endometriosis is what? Surgery. Now, how do we go about it? How do we take the treatment? Now, what is the purpose of surgery? The most important purpose of surgery is to cut away as much endometriotic tissue as possible to reduce the pain. Got it? Right? So you take away as much endometriosis as possible during the surgery. And there is no place, absolutely no place for open surgery in endometriosis. That is evidence-based, and that is a recommendation by all the endometriosis associations. There is no place for open surgery in endometriosis treatment. It is always and has to be laparoscopy because it gives 10 to 15 vision times vision. It gives the best possible way of sorting out all the tissues, right? Parting on and taking off the endometrial tissue gives the least amount of adhesions and the best outcome in endometriosis, right? Okay. Now, the principle is, it's like treating cancer. Take off as much endometriosis as possible, leaving as little as possible. And then if the woman has fertility issues post-surgery, immediately start fertility treatment, right? We don't suppress and start. We immediately start fertility treatment. So it may be IVF, it may be intrauterine insemination, it may be ovulation induction with timed intercourse, ovulation induction intrauterine insemination, or you can ask them to try and conceive naturally, because endometriosis, good surgery will increase the fertility rate by even 50%. right? So surgery, it's like treating cancer. Exercise as much as possible, right? And then continue with our fertility treatment. Is that clear? So that is for a woman who has pain, endometriosis, and who has fertility issues. So the mainstay in treatment with fertility issues is initially, if the endometriosis is not too much and if the pain is manageable and if there's no huge distortion of the anatomy, you can try your fertility treatment first, and then at some point you can go for surgery. Is that clear? However, if everything is distorted and there are a lot of problems inside and there's no way she can conceive, then the treatment is what? Surgery, exercise as much as possible of tissue that is possible, and then go directly for fertility treatment. That fertility treatment may be just natural intercourse, maybe intrauterine insemination, maybe in vitro fertilization, right? Or whatever, you go for fertility treatment. Is that clear? However, it's always a race against time, right? You clear the endometriosis, you try and get her pregnant. If she doesn't get pregnant, because we have to stimulate the ovulation, and that means very powerful ovarian hormones. And at some point, right, the endometriosis will flare up again. So it's like a race. If she gets pregnant, good. If she doesn't get pregnant, then again the endometriosis will come up, because it's a lifelong disease until she reaches menopause. Is that clear? Right? So the next step now is something more sort of things that we can manage more. What is it? If she has no fertility wishes, but there is pain. Okay? So what are the types of women we have? The types of women we have are the women with pain, right, with fertility wishes, right? So therefore, for women with pain and fertility, we can treat them with painkillers, but we cannot suppress ovulation or any medication, right? And therefore, either we, with the pain, we go for fertility treatment. If everything, if everything is not distorted, we, with the pain, with painkillers, we can go for fertility treatment. Okay? So that is one option. Or we can go for surgery and go immediately for fertility treatment without suppression. Is that clear, children? Right? Or there are women with so much distortion where to do surgery and go for fertility treatment. So those are the options available for these women. Is that clear? Then there will be a group of women who have severe pain, no fertility wishes because they have had children, and that group, our treatment and approach is different. In this group, what we do is we take away as many tissues as we can. So what are these tissues which we can take away? If there is a bladder involvement with the bladder nodule, we have to cut away the bladder nodule. Okay? Even if there's a, even in the women with fertility, we can cut away the bladder nodule. And then we have to leave the bladder because we can't take the bladder. If the uterus is involved with adenomyosis, severely involved with adenomyosis, if she has no fertility wishes, the best is to take it away. Because no amount of treatment, hormonal or otherwise, is going to really reverse our adenomyotic changes. Adenomyosis gives three problems. Very painful periods, very gives pelvic pain, dysmenorrhea, it can give menorrhagia, bleeding, and it gives severe dyspareunia. When the penis hits the adenomyotic uterus, it is severely painful. Nothing is going to reverse it unless you take it off. Right? So therefore, if there are no fertility wishes, if there is adenomyosis, you take the uterus off. When that happens, the pelvis frees itself. It becomes more free. The bladder is more free, there's more room, the bowel has more room to move because you have taken the center. And everything sticks onto the uterus. The ovaries, the tubes, everything there. So therefore, when you take the uterus off, it frees the pelvis and causes less pain. If there is hydrosalpinx, you take the tubes off. because if she has no fertility wishes, then the tubes can come off and it will cause breast pain. We hardly ever take off the ovaries unless it's very severely affected. Normally what is done is, we do cystectomies, take off the cyst walls and leave the ovaries because they will produce hormones for until she is about 65 years of age. However, if the ovaries are severely affected, then oophorectomy is a possibility, but we will need to give her hormones until she is about 50 years of age, right? So therefore, we can give them, offer them oophorectomy, but it's the last resort. Before we do oophorectomy, there's something which we can do. We can give them GnRH analogs, completely suppress the ovaries and find out whether it works for her. If the pain goes away and she's happy on that, then for a permanent solution, because we cannot go give GnRH for a long time, we can just do a oophorectomy and continue her on hormonal replacement therapy. You all understand? Right. If there is endometriosis on the bowel, what are the things we can do? Number one, we can shave it off. Right? Number two, if it is infiltrated in deep, you can cut it off like a disc, and then that is called discoid excision, and repair it. If the whole segment is involved, you just cut the segment off and then you join the bowel, which is called segmental bowel resection. That is what we do with the bowel, right? If there's endometriosis on the uterosacral ligaments, then we have to shave it off or cut it off. If there's endometriosis over the ureters and the ureters are stuck, then we have to do ureterolysis. We take the, or you do ureteric shaving. You take the endometriosis off, right? So everywhere where endometriosis is, we have to take it off or cut it off. And then, because there will always be endometriosis left, then what you do is you have to continue your suppressive therapy once if she has no fertility vision. So you can do a hysterectomy, do the shaving, do the bowel resections, do the ureteric shaving and all that. Once a complete, as much as which you can remove, and then you continue with your suppression. Usually the evidence is suppression with oral contraceptive pills for at least for a period of 2 years. That is the evidence. You understand? These are the women who do not have fertility wishes. Got it? So in a nutshell, this is endometriosis, and this is how endometriosis is treated, right? So let's summarize so that your brains get into order. Number one, there'll be mostly 3 groups of women, 3 or 4. What is the first group? Women who are having pain, okay, and no fertility wishes. This is probably the easiest group to treat, okay. So if there is pain and there is no fertility wishes, what is our approach? Yes, we can initially try with medical therapy. We can initially try with ovarian suppression because they have no fertility wishes. If that doesn't work, we can go for surgery and take out every organ that is not necessary, like the uterus and the tubes, and excise as much as possible the endometriosis from the remaining organs, and then go for suppressive therapy like oral contraceptive pills for a long term. Is that clear? That is the first group. Is that clear, children? Second group, women who have pain and they have fertility wishes. What do we do? Initially, we can go with painkillers and then go for fertility therapy. If that doesn't work, we can go for excisional surgery, properly excise every piece of endometriosis we have, and then immediately go for fertility treatment. Is that clear? Along with painkillers all along the way. That is the second group. Third group is what? No pain, infertile. However, they have endometriosis. In that case, you might need to think, okay, is surgery necessary if there's a lot of endometriosis without symptoms? So we do a excision and clearance, or we can try with fertility treatment for quite a bit of time because there is no pain. Okay, that is the third group. What is the fourth group? women who present to you with severe complications, right? Hydroureta, hydronephrosis. No option, we have to treat them surgically, right? So that surgical may be reimplantation, segmental resection of the ureter, ureterolysis, all those can are treatment options, right? There's another fifth group. What is that? Women who are involved with nerves, where you have neuropathic pain. That also, no option, is always surgery. You need to clear the endometriosis of the nerves, right? So that is the treatment summary for endometriosis, which you need to understand. Is that clear? Yeah, right. So switch on your videos. I want to see a few of you all because I need some input, right? Now, what I want to understand is, right, so since we have discussed endometriosis at length, right, you all got a good overall view of it, right? Do you all want to see some videos of endometriosis, children? Yeah, right. What is the time? I'll show you some short videos, right, where you can see how bad endometriosis is, okay, and what it is doing to women who have endometriosis, right? Okay, so let's go back to, so we'll just do it, finish it off in 10 minutes after, right? So that I will share some videos that you might find interesting, because after speaking about it, right, do you all have any questions that you all want me to answer before we switch on to a few videos, so that to make you all understand what really endometriosis is and what we are dealing with. Any questions? You all can unmute yourselves and ask.
Yes, sir. I have a few questions.
Yeah. Okay.
Yes, sir.
Few questions
Yes.
is alarming, but still okay. I will try to answer them.
Yes, sir. If in a question, if they mention it as pelvic endometriosis, does that include ovarian involvement as well?
Yeah, because ovaries are a pelvic organ. So yes.
All right, sir. Thank you, sir. Can endometriosis present as amenorrhea, secondary amenorrhea?
Secondary amenorrhea, no. The problem with endometriosis is bleeding. So when you bleed, you have problems. So it doesn't present with amenorrhea.
With ovarian involvement, could it?
No. The ovaries will become large, still they'll be producing hormones. So that cycle will be going on. It is, the problem is that the cycle is going on, right? Because it is producing cyclical hormones. That causes the endometrium that is in the other two swell up and bleed, swell up and bleed. So if there's amenorrhea, our problem is settled in a way. It's not going to bleed, okay? So when we do hormonal treatment, or when we are trying to suppress ovulation, we are basically trying to achieve amenorrhea in women who have no fertility wishes, and but we are trying to achieve amenorrhea. You understand? So amenorrhea is a good thing for endometriosis if the woman does not have fertility wishes. Okay?
Yes,
right.
Sir.
Any other questions?
Yes, sir. Does pregnancy cause the endometriosis to regress?
Yes. So pregnancy is a progesterone dominant state. High doses of progesterone will cause decidualization or suppression of endometriosis. That's why we use dipomethylhydroxyprogesterone acetate in very high doses, so that it suppresses a bit of endometriosis. However, usage of DMPA is not a very excellent practice and should be limited to a very selected cases only, right? But yes, it is an option, a medical option, to cause suppression of endometriosis.
Right, sir. Okay.
Okay. Any more questions? Please ask away. This is your forum, and this is absolutely free session. So please ask away. I will answer any question that spring into your mind. Don't be shy. You can even switch off your videos and ask the questions if you want to.
Excuse me, sir.
Yeah.
Sir, does adenomyosis lead to postcoital bleeding?
Does adenomyosis give postcoital bleeding?
Yeah.
Usually not, child. Postcoital bleeding can happen when there's initially if there is a valval issue, right? There can be valval tears, the fourchette can tear, it can have. So you see, when you look at postcoital bleeding, you need to find think throughout the way. Again, valval injury swelling end up vaginal injury swelling end up, right? There are sometimes you can have very severe postcoital bleeding because there are spiral tears, which is very difficult to treat also, right? It will need suturing in the theater also. And then if there are cervical lesions that bleeds on touch, that will also cause postcoital bleeding. And if there are polyps that are inside the endometrium that can get disturbed, that also can uterus expand because orgasm and coitus causes uterine contractions and posterior pharyngeal contractions in the muscles, right? That can squeeze the blood out from a polyp or can cause bleeding from the uterus itself. So therefore, postcoital bleeding, that is why we check for endometrial polyps as well, right? So adenomyosis itself should not give postcoital bleeding because adenomyosis means from the endometrium, the endometrium infiltrates into the myometrium. From the endometrium out, right? And so nothing is going to come from the myometrium into the endometrium to bleed as a postcoital bleeding. Do you understand?
Yes, sir. Sir, and does it cause intermenstrual bleeding, adenomyosis?
Usually not. Endometriosis can cause because it might disturb the hormonal milieu, but adenomyosis itself may not cause intermenstrual bleeding.
Okay, so thank you so much, sir.
Remember, there are no fast and hard rules, children. They can have the endometrium can be hyperplastic. There may be problems, polyps in the endometrium in combination with endometriosis and adenomyosis. So it can be few pathologies grouped together. So don't look at a patient like having a textbook image and will come to you and say, okay, I have only this. Do you understand? It can simply be a mixture of problems. Okay, so they can present in various ways. Okay.
Thank you, sir.
Right. Any other questions? No? Videos? Or sleep? What do you want? Videos or sleep? Hands up who wants videos? You can, yeah. You all can put your hands up now from this, from your reactions. Okay. Looks like all of you want videos. Okay, fine. Okay, you can stop putting up your hands now. Right, children. Okay, now let's go to the share screen thingy.
Does the videos have sound?
Sorry, I will open the videos up first.
Hello?
Yeah.
Yeah.
Sorry?
Does the video have...
No, it doesn't have sound. These are all my laparoscopic videos. I'll be showing very short segments, right? There's no sound. You can still see me, right? Yeah, okay. All right, I'll just show you a few interest. You can see me, right? Hi.
Yes, sir, we can see.
Yeah.
Yes,
okay.
sir. Yes, sir.
Right. First, I'm just going to show you a few videos. Okay, I'll just show you a few interesting things. First, the bladder endometriosis. So this woman had severe pain, right, during her she suffered so much of pain, right, that she was in agony actually. She could not pass urine. Every time she wanted to pass urine, it was a dreadful experience to her, simply because there was a large bladder nodule sitting. So I'm going to show you the cystoscopy of a bladder endometriosis, okay? So right, share screen, and now, do you all see my screen, children? Can you see it? Nod your head.
Yes, sir.
Sirisena, I can see you. Nod your head. Right, okay. So this is a cystoscopy, and what you are seeing here is a bladder nodule. Loku ratuwata penne naha. Oy tiyenne. Can you see? Can you see my cursor? That is the bladder nodule. Do you all see my cursor? Sirisena. So that is the bladder nodule reaching hand. So there is the uretary orifice. This is one uretary orifice, and this is the this is the gel which we use to do the gel. Okay, so this is a large bladder nodule, right? So I will stop and I will just show you another one, a bladder nodule. I will show you how it is cut away. Right, this is what we call a Collins knife. Right, wait, I will show you. Right, we use a special knife called a Collins knife, where we just cut off the bladder nodule, which you just saw. This is the bladder nodule you just saw. You see? Can you see the screen? So this is, there is actually monopolar, and then you just cut around the nodule and you resect the whole thing off. I'm going to just, can you see how it's been cut? The same thing. See? So this woman, actually she did not even conceive because of this pain, right? See how it is been cut off, and this will cut right through into the peritoneal cavity. The rest of the resection will be carried out laparoscopically. So it's a groove is cut around through the bladder. This is, you are looking inside the bladder, right? And then from the peritoneal cavity, laparoscopically, that whole nodule will be taken out and the bladder will be resutured. Can you see how the nodule is being cut off inside? Then that groove can be seen from the other side, and then it can. So actually this woman conceived 2 months after the resection. She was infertile for 11 years, and she conceived 2 months after this bladder nodule was taken off, right? So, and she has delivered also, I think, by now. She was from very far away. She was referred to our center at Kalubewila after this, and therefore then she went back and then she delivered there as well. But she called us and told us that once the pain has gone away and everything, she's fine. Okay, I'm going to stop this video. So that is a bladder nodule. Okay. Right. Next, I will quickly show you a bowel nodule. Okay, bowel. So now this is a bowel nodule, which is bowel endometriosis, which is being shaved. Can you see my screen? Sirisena? Nod your head because you are the only person I can see in my.
Can see, sir.
Good. So nod your head because I can't see. So can you see that is a endometriotic nodule on the rectum? Can you see that? What you are seeing is here is that there is a nodule and it is being shaved off. This is up there is the uterosacral arch which you can see. That is the nodule being taken off. Okay. So that is the bowel nodule. Okay. Next, I will show you a discoid nodule. That is also endometriosis. Right. This is also endometriosis. Yes. Can you see me? Can you see my screen, children?
Yes. Yes,
Right.
sir.
So this is, you say, discoid resection. There is endometriosis on the bowel, right? So proline thread is put through the endometrial nodule. You can see that the whole bowel is infiltrated with endometrium. Can you see that? Right? And the staple is put in, and that nodule is stapled off and cut off. So that is called excision. Yeah, that is the nodule that has been taken off. So the pain actually goes away. So that is a discoid excision. Not a discoid, actually, it's a, yeah, with a linear staple. Right. Okay, so that is one type picture. Now I will show you a ureteric problem, right? Okay, now this is a ureteric reimplantation. I'm going to show you due to what? Okay. Now in this patient, what has happened is endometriosis has caused the ureter to become big. What is that called? That is hydroureter. I told you, remember? I think that is that. So I will now share that. Yes, Mrs. Sirisena, can you see me?
Yes, sir.
Not me, the screen.
I can see the screen.
Thank you. Right. So this is a ureter and this woman has hydroureter. I will quickly, I'm going to jump through because I just want to show you where the problem is. Right? This was done long time ago, 2015. What are those funny sounds coming? I don't know. Can hear some funny sounds. Okay. Right. I'm going to go quickly. Okay. Sorry. Right. So what you are seeing red here is endometriosis, right? So I'm going to go quickly. Sorry. Right. Now you can see what I'm holding on to the left here. Right. Annotate. Draw. Right. This. So can you see this, children? This is the ureter. Hello, Madhuka? No, no. Okay. This big thing, can you see this blue thing? All this is the ureter, very, very large. Can you see that? And here there is endometriosis causing it to be obstructed. Okay. Right. So I'm going to and I'm going to quickly skip. Can you see how big that ureter is, children, on the left side? Loku kambeyak wage. That is a hydroureter. Okay. And that is the endometriosis that is causing the constriction. So I'm going to go still. Can you see how big the ureter is on the left side? Can you see that? And that is where the endometriosis, it goes and becomes very small. There, where the bleeding is, it has become very small. So it's a hydroureter. And this woman had hydronephrosis as well. So I'm going to go that. Can you see how big the ureter is? Right? All this is the ureter. And this is endometriosis. That is what's causing the obstruction. Do you see actually what it does? So this woman has a. So beyond this, the ureter is of no use. So what do? Because we cannot salvage this ureter. So there, can you see how big the ureter is, children? Loku pol gahak wage. So that's a typical hydroureter. Okay, I'm going to just go very quickly. And okay, that is the bladder being mobilized down. The ureter has already been cut, right? That is the bladder being brought down because there is not enough length for me to go and put the ureter there. So that's what I'm mobilizing the bladder. That is, I'm just cutting away the endometriosis on that side. That is of no use. And then you can see that is what is called a psoas hitch. The bladder is hitched onto the psoas so that it does not go back, right? So that then we have enough room to put the cut ureter onto the bladder. The ureter kapala දැන් අයින් කරලා තියෙන්නේ. So I'm going to just show you that part where I have the pleasure of cutting the bladder. Now the bladder has been cut. So a stent is put in laparoscopically into the ureter on one side and the bladder onto one side. Or ureter එක කපපු ureter එකට stent එකක් දාලා තියෙනවා. You can see the cut bladder here, and then what is done is it's put onto the stent is put into the bladder and the ureter, and then slowly the stitching is done. Can you see how the stitching is done there? Slowly the ureter is re-implanted into the manner. Now there are loku mahatvecha, the large sort of ureter is slowly becoming small. So this woman had a very uneventful recovery. You can see the ureter there. So that is the ureteric reimplantation, because the endometriosis down there has caused obstruction of the ureter that in the place where it falls into the bladder. Can you see that is called a ureteric reimplantation? Okay, right there, ureter. So that is the ureter. Okay. So that is, I showed you bladder, I showed you bowel, I showed you the ureter. Okay. Next, I am going to show you one more thing. So you have seen a lot of things now. Right, okay. I'm going to show you some endometriosis of the vagina, and we are going to stop this session. Right, can you show do you see my screen?
Yes, sir.
Good. Right. So this is the initial view. I'm going to just go quickly. At a glance, it seems there's no endometriosis, but all this we are talking about is deep infiltrating endometriosis. But you can see how stuck everything is. Can you see that? So there is the uterus which is being antiverted. You can see the ovary is stuck. You can see the tube stuck. So this is very, very, very severe endometriosis, right? Then this is, you can see this reddish areas is always endometriosis. So the intention is, of course, to try and excise it, because this woman probably required fertility, right? So I'm going to, so one ovary has been freed, and then it is lifted onto the abdomen and put in there. So we have access into the pouch of Douglas, okay? So you can see on the left side also, you can see everything is stuck to each other. The round ligament in the middle, you see the tube, and from the tube, the bowel, the rectosigmoid is stuck onto the ovary, right? So everything is stuck to each other. You can see how bad endometriosis is, because normally it should be a very smooth sort of surface without any problems. They need to slide over each other, shining. It has to be a beautiful surface. But what has happened here? Everything due to all these reddish areas, these are all endometriosis, active endometriosis, which is causing destruction of the normal anatomy. And you can imagine how much of pain it is going to cause this woman. Okay. So slowly, this will take several hours, right, of surgery. So now I'm going to quickly show you. Now here that is the ureter. I'm looking for the ureter. So the ureters must be freed before anything else to make sure that we do not harm the ureters while exercising it. So this is the left side ureter. So I'm looking for the ureter. All right. What I'm going to show you now is slowly everything is getting freed. The bowel is also getting freed. You can see the ureter, the ovary has been sort of, both ovaries are suspended, and where I am going is what is called the pararectal space. Pararectal space are the two spaces between the bowel. So that needs to be freed, and the ureter, we need to see the ureter, the bowel, everything before we cut away the endometriosis, right? So I'm going to just, you can see how bad the endometriosis is here, and I'm going to just go quickly, and that is the end of the vagina. When I'm pushing, that is the end of the vagina. So since there's endometriosis around this, vaginal intercourse becomes very important. In this particular woman, there was a large vaginal nodule, right? So I will show you, okay, and wait. So now the vagina is getting open. Can you see? The vagina is open, and you will now in a moment see the vaginal nodule. This was causing a huge amount of, that is the top of the vagina, and what I am holding is the endometriotic nodule. So I have to cut it away. So I'm cutting away the vaginal nodule from her. This was causing a huge amount of pain, and this was of course causing her severe dyspareunia. Can you see the thick ending? It shouldn't be thick like that at all. The vaginal wall needs to be very smooth. So that is the whole nodule, and that is the vagina, which you can see from above. And that is I am holding the nodule and I am cutting it away, so that once this whole nodule is excised and the vagina resutured, she did not have any dyspareunia. So now once it's cut off, I just expel. Now you can see that the nodule is gone. So I'm suturing the top of the vagina. Yeah, I'm closing the vagina of the excision of the vaginal wall, right? That is closed, right? So yeah, so that is another bowel nodule. I think I'm going to I have to shave that off, right? There, the bowel nodule is being out. So that is bowel. So this woman had severe dyschezia as well. So I'm shaving the endometriosis of the bowel. That is the bowel nodule coming off. So this is shaving of the bowel nodule. There, can you see the bowel nodule coming off? That is the endometriosis that is causing a lot of dyschezia. That is the bowel nodule. Right. So that probably is enough for today. Right. Right. One moment. Right. Okay. Fine. So that I think has given you a good overview. Yeah. And also a comprehensive look at what endometriosis is, how it is diagnosed, what the symptoms are, how the symptoms are explained, right? What type of women will come to you? Basically, women with pain, no fertility wishes, women with pain and fertility wishes, those are the most difficult to treat. And then there are women with no fertility wishes and pain, and there will be women with different complications like hydronephrosis, hydronephrosis, right, who will come to you, right? So I have spoken to you the ways of treatment, what we do with medical therapy, what we do with surgical therapy, right? And after that, I have shown you what really endometriosis looks like in the videos which are. So I have shown you bladder endometriosis, I have shown you bowel endometriosis, I have shown you discoid excision, I have shown you rectal shaving, I have shown you uterosacral shaving, I have shown you a vaginal nodule being taken off, I have shown you ureteric reimplantation caused by endometriosis because of hydroureter, right? So I have shown you a lot of endometriosis today, right? You all understand? Right. So this is what we are dealing with, and this is not a very good disease. It's a bad disease to have, and but we can do a lot to sort most of the things out as well. Okay, right. Any final questions in the chat? There are few questions. Sir. Somebody has said, "Can't see, sir." Did you all miss some of the videos? So it is specifically for the lady. Did you see all?
Yeah, all videos.
I think it is your connection, lady. Right. There's a question. Sir, if it is an unmarried woman, can we rely on a transabdominal ultrasound scan instead of a transvaginal scan? Not really, because that is the only question that is there. So I will answer that. The best way, although it might not be very easily acceptable, the best way to look at endometriosis is by vaginal scan. However, if she is not sexually active and she does not wish a vaginal scan, a rectal scan is another option, right? So because the probe is a rectal/vaginal probe, so that probe can be used as a rectal probe as well, right? To make so therefore, in Sri Lanka and maybe I don't know in other countries as well, we those who are dealing with endometriosis, we sometimes do rectal scans for younger women who are sexually or have never been sexually active. It gives us almost the same view and give us almost the same information as a vaginal scan, right? So that is one option that is left to us. If you want to diagnose properly endometriosis, because endometriosis, if you do a proper vaginal or rectal scan, we have to look at a lot of things. We have to look at the uterosacral ligaments, we have to look at the bowel muscle cord, we have to look at the vaginal nodules, we have to look at the adenomyosis and diagnose adenomyosis properly. We have to check whether there are adhesions between the ovaries and the uterus. All those cannot be done by doing a abdominal scan. So, you know, it's not a good professional way to try and diagnose endometriosis. You can see, yes, definitely you can see the large endometriomas, ovarian cysts, but that is very high up. But we cannot diagnose any of the deep infiltrating endometriosis properly with an abdominal scan. That is impossible. So therefore, it's transvaginal scan. If that is not possible, you need to really consider a rectal scan. And to look at the nerves, to recap, the scans are not going to do that. That is only MRI, right? So, but the rest of most of the things we can diagnose by a vaginal or rectal scan. Right? Okay. Shall we then wind up? There are hands up. Okay. Can you? Yes. Yes. Sajida Mansur, do you have a question, child? Oh, මොනහරි එකක එබිලාද ඔය hands up එක තියෙන්නේ. Sajida, do you want to ask a question, child?
No, sorry, sir. It's a mistake.
Oh, I thought so. Right. Right. Okay. Okay. Are we done then? Right. So, what I want you all to do is to type into the chat what you all want to do. Remember, whether you want to do a question and answer session next time on endometriosis, or whether you want me to do what is this? Just another teaching session, or 3, whether you want me to do a sort of a mix, do a class and then answer some questions from the previous session, right? So therefore, I think the next time, just tell me so that we can organize next class. What do you all think? come out quickly because we need to finish this session and make a decision about the next session. Yes. Come on, quickly. So unmute yourself and talk, so that then we can plan the next session than going through the chat again for me. Because if you all want a question and answer session next time to discuss SCQs and all that, then I will need you to send me questions on the chat in Telegram. Okay, so that I can collect all the questions, whether it is SCQs or MCQs and all that, and discuss it at length next time. So that whole session will be question and answer if necessary. So what do you all want me to do? Yes.
Sir, can we go for the third option, sir, where we can do a new topic, but we can also ask you whatever doubts or MCQs, maybe like whatever doubts we have, sir? Is that okay?
Yeah, so that is one option. What do the others think?
I also think that will be good, sir.
Okay. Any other opinions? Because people can have different opinions. So please tell me. Yes, come on. Yes, Mr. Kavisha. Give an opinion. Right, somebody else, you can also type into the chat. Sir, I'd prefer class like this next time too, my personal view. So which means just a teaching session. Next, Shashikal, question and answer session better. That is purely good. Third option is a mixed option.
I think
Yes. Somebody has put in theory and questions. So what we'll do is, shall we just type into the chat so that I will see, which is just after this session. Can I just type into the chat and see, right? So what goes is what the option number 1 is continue just study sessions, no questions and answers. Okay, just a small question and answer session at the end, like what we did today. Option number 2 is session, then a teaching session, then a complete question and answer session. Teaching session, question and answer session, right? That is option number 2. Option number 3 is what? New subject, about 30 minutes of question and answer from the previous session. Okay, that is number 2. So can you just type it into the chat there about now? Yeah, then I can just see which is the most numerous and then I will put down, right? Now, so shall we do that then, right? Okay then, good night then. I will put this online anyway.
Okay, thank you, sir.
So people can, check it out who missed it. Okay. Good night.
Thank you, sir.
Right, sir.
Thank you, sir.
Thank you, sir.
Good night,
Thank you,
sir.
yes, sir.
Thank you, sir. Thank you, sir.